Thank you for the opportunity to give this talk. I'm going to change courses a little bit and talk about the really important part of the center of the chest, heart and the covering of the heart. I'm a transplant, advanced heart failure, mechanical cardiologist. And the difference between lung transplant and heart transplant, for example, is we cure AFib, they create AFib. I have no relevant conflicts of interest. I do have some financial conflicts of interest that are not relevant to talk, and apparently have so we talk about pericardial tamponade. Some people call it cardiac tamponade. And actually, I think cardiac tamponade is probably a better way to talk about it, because pericardial tamponade does not require the pericardium. It just requires the heart to be in a constrained space, whatever that space is. Usually, you're born with your heart constrained by a pericardium. Usually, you're born with it constrained by the chest wall. And so, whatever box you put that heart in, regardless of whether it has both a parietal and visceral pericardium, have in a constrained space, you have finite volume that you can manage. One chamber goes up volume, then it's in a defined flexible space. The chamber has to go down. It's an elevation and equalization. All the pressures in the chamber of the heart is used. So it doesn't mean that you still have blood pressure. You can still have right atrial pressure or systemic pressure. But when the systemic pressure falls, your LV end diastolic pressure, RV end diastolic pressure, so not your when it comes inside the heart, that falls, that comes to the same pressure, right atrium, left atrium. The compression can be due to fluid, air, or solid. We'll focus on fluid or air later. And again, it's interdependent filling. It's a zero-sum game. And then if you fill one chamber, you lose volume. The pericardium is fibrous and very thick. So this is a visual illustration of what you have here is if you are filling the right atrium, having compromise. If you're filling right ventricle, this is in some ways very similar to at RV filling. However, in this case, because of this, that's how it collapses. Or you can have diastolic collapse with RV3 wall. RV. You have these reciprocal. Is the dynamic changes in intrathoracic pressure. So again, the intracardial pressure starts meeting or exceeding the intracardial pressure. You have very small derangements. We get derangements of wide swings of intrathoracic, resulting in smaller changes in this constrained pot. I'll call the round pericardium. And so your intrapericardial pressure are at where you can have intrapericardial pressure at RV, fast, RV. Those are the echocardiographic findings. And then I just wanted to show you this slide. Pulsus paradoxus is a classical finding. Pulsus paradoxus is not pericardial. Bad COPD have high respiratory. But pericardial, if you didn't have pulsus paradoxus yesterday, you may suddenly. And so this is just a visual way of how to assess and what pulsus paradoxus is. By show of hands, how many people are ER physician? But you will never be able to successfully do this because ERs are too loud. So unless you have a very quiet room with a patient that's very acute, so if your cardiologist is telling you check the pulsus, they're well-intentioned, they just don't realize that you have so this is a very, because what happens is you have all based on dynamic preload. Like what happens when you have exhale? However, you drop radiation are going up. So you'll see the stress here. Above here. But if you're middle, you're come down. You'll hear every single one. You might hear. So you'll hear every single beat, maybe even very. So that's pulsus paradoxus. So what can cause pericardial tamponade? Well, fluid can do it, and I'd classify it according to a very simple algorithm of is it blood or is it blood? So bloody, malignant, if it's actually blood, check right on it if you actually happen to have the fluid, and malignancy is not grit, but it just happens to look like it. But you don't need a slide to tell you what the differential is. It's really just very simple. Is there trauma? Was it one of Dr. Foreman's patients? Were they just in the OR? Did they just have a surgery? Was the cardiologist just around? So, in fact, in the inpatient setting, or for the ER docs that are called to a code in your hospital, perhaps, and an inpatient code, patient just had a stent, thinking, oh my goodness, what if this patient's coming into the ER? They could have in-stent thrombosis. They could, or it could be something you don't see them walking into the ER with because they perforated the coronary artery with the stent, and now they have something else and they have a different cause of hypertension. So it doesn't have to be ischemia, it can actually be coronary laceration, perforation. The knife and gun clubs, I grew up around Denver, so we had Denver General. I don't know if we have see knife and gun club on Friday nights, if that's what we call it or not. Okay, so it's a daily occurrence here. So it's a knife, gun, shrapnel, barb, anything that you can throw into the chest. Post-infarct, if you give heparin, you can get a bloody pericardial effusion from inflammation that would have been non-bloody until the heparin came around. You can have inflammatory causes, just pericarditis, autoimmune, Dressler's. If you transect the chest just the right way, and it's very rare you would ever get a chylous pericardial tamponade. It would take a long time. But you could have, for example, TB or something else. Infection. So other media for pericardial tamponade. Remember I said you don't have to have a pericardium. Heart transplant patients don't have the outer pericardium. And so they're still constrained, however, by the chest wall or by whatever fiber structures decide to contain the heart when it's starting, if there's bleeding around it. If you have a pneumothorax, you can have your lungs inflate so that they just as you were trying to stabilize the chest wall, you can actually stabilize the lungs so they're a rigid structure and there ain't no space for the mediastinum, and it's getting crushed, and it's effectively pericardial constraint. So you can do that also by cranking the PEEP way up, why some of those patients will be expensive. And I've actually had I remember when I was a medical student, we actually had one 90-year-old gentleman who decided to die. He was eventually pronounced after prolonged code, and he said, "I'm not quite dead yet. I'm alive. Stop, save me," because you were overinsufflating my lungs. So excess insufflation by respiratory therapists. So that's why it's actually critical in a code situation to not overinsufflate. So diagnostic modalities. If you call a cardiologist to ask if there's tamponade, they may or may not be able to tell you if they're reading echo. Because if you say there's tamponade and the cardiologist says that there's not tamponade, there's tamponade. There's tamponade until you prove there's not by actually taking fluid. So an echo, it's really important. An echo can be suggestive, consistent with lack of findings of tamponade. You think tamponade doesn't mean there's not tamponade. Now, usually if you volume resuscitated, a Swan catheter should demonstrate that because it should be equalization of pressures. But most of the times you won't have a Swan-Ganz catheter. But if you do have one, you can refute, rule in, rule out very quickly. Things that look like tamponade that aren't are bad heart failure. Other than that, or constraint causes restrict cardiomyopathies. But outside of those, if you have equalization of pressures, you need to at least think about tamponade. We talked about the echocardiographic findings, diastolic collapse, ventricular independence. So on the echo, what they'll do, and I'll show you later, they'll look for inflow patterns across the mitral and tricuspid valves for exaggerated respiratory variations. I talked a little bit about that if you have a Swan-Ganz catheter, or what I'll call a Swan-Ganz Chatterjee catheter. Does anyone know who Counter Chatterjee was? He was Swan-Ganz's fellow in a lot of the thing. He just passed away a few years ago. He's an awesome human being. And so sometimes you can also just put two and two together sometimes. Where is the wound? Where the patient comes into the ER, you might not know if there's pericardial tamponade, but you know you need to explore the chest. And there's the academic way, put a swan in, and say that there's equalization of pressures after you've drained it. Or sometimes if it's just clinical, you know it's there, do the test of cure, drain it, go for it. So who do you call when you want to do this test of cure? Well, it's pretty simple. If there's trauma or rupture, you want to call cardiothoracic surgery in general. There are some exceptions. One exception is a cardiothoracic surgeon's chest pain. Survive. Otherwise, you're going to invasive or. Well, I mean, this is very serious. I had a patient very recently that had tamponade, and that we knew. Well, if we took him to the OR, no anesthesia, and this patient wasn't going to survive induction, wasn't going to survive long enough. So he had to do an ECMO and then put. But outside of that, like was an ECMO. Something stabilized, so there was sort of a teamwork. So you can always call cardiology first if they can run it right. But if it's after a coronary stent, you probably want to call the interventionalist. So the choice is dictated by which tools you're trying to get to apply. You can do the pericardial window, which is basically connecting left pleural space or pericardial, getting a cavity, or you could actually just go in directly subtype the pericardium. For pericardiocentesis, the way we do this is generally we do it the wire first. In there, you get it. So as you advance it, it's tracing the injury current. And actually, as you off the pericardium, actually feel that resistance basic. You have a danger with it. Artery, deep red, as like to say, you try to avoid that. So if you ever have to ever have to cross, so you get a spoiler. Yes. We try to drain things, see it. So in medical school, we're taught about electrical alternans. This is a cool finding. Lack of it should be clinical diagnosis. It's just an extreme manifestation. A lot of times, electrical alternans really requires the heart shifting space. The amount of volume that it creates to cause pericardial tamponade is, if you did not have any cardiac 5 minutes ago, 50 to 75 cc's in pericardial space and try to. However, if you've had long-standing malignant pericardial effusion creeping up on you, growing and growing, sometimes so the volume is not the thing that correlates with whether there's pericardial tamponade. So pitfalls, there are no absolutes. Not all patients read the book. There are no single diagnostic features. The very most common feature is dyspnea. A lot of times you'll have a cardiologist say, is the patient tachycardic? Well, care if the patient is tachycardic. Oh, but not all causes of tachycardia are from this. And lack of tachycardia doesn't tell me that the patient has 6 sinus and tachycardic. So tachycardia is less significant than dyspnea. I had a patient recently that I'll talk about later, how dyspnea feature was to his diagnosis. So dyspnea is the most sensitive. Tachycardia is actually only about 3/4 sensitive. Pulsus paradoxus, it's still pretty decent. Elevated JVP, we always say look at the neck veins. Resuscitation. It's probably, if you have counter-chattergy, this is probably about 99%. All comers, it's only 3/4. And then cardiomegaly, if it's acute, you might not see cardiomegaly. If you have a really experienced, very good chest radiologist, plain film can actually show the loss of all the recesses, left atrial hump on chest X-ray. However, you might not be getting a good chest X-ray because it looks acute. So classic findings are not necessarily classic. So lack of cardiomegaly, lack of electrical alternans shouldn't trump what you think is going on. It's an emergency. Don't wait till the patient collapses. Cases. People have tried to wait. Patients not hypertensive. I said, hypertensive. For short of breath, you're thinking tamponade, it's not hypertensive. When they do become hypertensive, they might not. And I will say, you don't have an opportunity to all patients pericardial. Your EMS is arriving to a patient pericardial tamponade killed. You don't expect it to salvage that patient. That's the extreme experience. So how do you have tamponade without tachycardia? First of all, patient could have a normal heart. Look, didn't read it. Patient could have a pacemaker, 6 sinus. They will always be 7, no matter what you do to them. They could have had AFib with an AV nodal ablation, great AFib with slow ventricular response. They're never going to be hitting tachycardic. It could be the patient just had an MI, had an RCA stent, is now bleeding from the RCA, but they have conduction disease and they're trying to actually die from bradycardia and tamponade at the same time. Or you could have a patient that has persistent tachycardia that relevant heart transplantation. Those of you in the car when you transplant recently. Think about your car. How many of you that are ER drive automatic? One minute. For everyone that drives automatics, drive up the street light, stop at the red light. Why is your car stopped? Because your foot is on. Let off the brake for the gas. Pull forward. We're testing heart rate, innervated. Slowly. Once you innervate heart transplant. So post-heart transplant patient might be going 80 days, their heart's a little slow. So the hypotension you get if you do have pericardial tamponade, first step is it's very patient comes in with no functional fluids. The fluids can help stabilize, but if it's a slow process, you can start getting end organ failure, including renal failure, either because there's not enough cardiac output, because there's pending cardiogenic shock, or it could be because your radiator pressure is now 30, 35. There's, I call one form of cardiorenal syndrome of nephrosarc, of renal venous. Your venous pressure is so high in your veins that you're trying to perfuse it here, but trying to go down very shallow. So renal failure is one of the other manifestations of slowly progressive tamponade, sort of a subclinical tamponade. You'll still save the patient, it's just that they're not about to die immediately. They're trying to die of the renal failure instead. Very challenging situation to find for anyone that is inpatient, trauma surgeon, anyone on the ECMO team, is tamponade, especially on PA. I can basically take away. You may get chatter, you get chatter. May not recognize, or it might just be very actually. I've seen this probably half a dozen over the first short career so far, and every single time it's either been a surprise additional thought process of, okay, we're going to screw in temporary pacemaker, wonder that perfect, see it, check it out, make sure it's perfect. Or it could be because the patient's having a check. So this is a patient that I actually saw in clinic yesterday. I apologize, I wasn't able to create a video out of this. But this patient was transplanted the first week of this month. And the rest of it, when they took this patient emergently to the OR, eating, fixed it, and well, and actually feels already better than she did basically for the last 2 years. So when you're in Australia and you're a physician, you hear hoofbeats. Sometimes you think zebras, but sometimes you think other critters that are a bit of Australia. So Steve Irwin, unfortunately, the crocodile hunter, died of a stick bite. And you'd think that these are pretty uncommon, but they're actually not they're uncommon, but not necessarily rare. You'd be surprised how many of these you find in the literature. So this was a review. This is actually this is
looking for that.
So it's actually a very informative thing because it actually can unify some of the themes of pericardial tamponade. So this is on the right is a review of just different cases of different examples. New Zealand woman died after a stab wound or stingray. Her at autopsy, her ventricles were completely transfixed by a barb. You'd be surprised how often that actually happens in the literature. This is not the only one I'm going to show you. In 1945, an Australian soldier died after a stab wound to the LV, sustained while swimming. Pericardial tamponade from LV laceration. A 12-year-old boy in Queensland, Australia, died after penetrating injury from a stingray. There's myocardial necrosis, but in this case, there was also perfect nod. And the fisherman here actually, I think, survived after being operated on for penetration of pleural pericardium muscle, but not the stab itself. And then, so the interesting thing about the one on the top, this particular paper, was actually stingray. Any of the above actually mimic that or infarct. Actually, lacerated artery. Respiration, RV, duration, and in case you're wondering, I think you're wondering about one of the things is stingrays tend to back on the first. So it could be that you're actually approaching any of these. This is another example of transfixion. I told you this would not be the only one. And so this is, we actually went through both ventricles together. And then finally, this is probably the coolest case of all those. So it's an unusual case of coronary thrombosis. You might even call it a zebra or stinger. So this patient had a RCA infarct, had a 40-year-old runner that had chest pain after running. In-stent thrombosis, restented, and then had another in-stent thrombosis. The history, when they finally took it, said, oh, I was 17 years ago, I was stabbed with a dead stingray. Someone actually stabbed him with a stingray. That was still there. He thought they had but there was a still, by CT, you can see that still this. And this was, I have to, it was, I actually I have it cropped here and hidden, but I'll yeah. The coolest thing about this is a justified photo. I'm sorry. So stingray was dead, like the ear doc, right? Most common cause of being this guy 17 years ago stabbed with a thing. Lacerated. That does illustrate